All right. Welcome back, everyone. Happy Thanksgiving and happy match day. I'll just take a couple minutes early just to tell everyone a sneak preview for the remainder of our calendar year of grand rounds. So today we kick off our 3 final grand rounds of the calendar year. And we will have 2 back-to-back lectures on aortic stenosis, which I think will provide complementary perspectives on the diagnosis and contemporary management of AS. First from Sammy Elmariah and then from Philippe Pibereau next week. And then I want to make sure that everyone has on their calendar that we'll end on the 13th of December with a special hybrid grand rounds with Dr. Michelle Albert on adversity and academic medicine, where she'll talk about career truths, recruitment, retention, and success according to race, ethnicity, and gender. That will be at Nursing Building 217. So I hope that especially our Parnassus colleagues can show up and listen to what I anticipate will be a great grand rounds with Dr. Michelle Albert. So without further ado, though, we'll get to the topic today. We are again joined by Dr. Sammy Elmariah. He is a UCSF Associate Professor and Chief of Interventional Cardiology. He specializes in caring for patients with heart valve disease, coronary artery disease, and adult congenital heart disease. He has particular interest and renowned expertise in transcatheter heart valve procedures, including transcatheter aortic valve replacement, or TAVR, transcatheter edge-to-edge mitral valve repair, mitral valve replacement, and the use of investigational devices for repair and replacement of the tricuspid valve. Dr. Elmariah's research focuses on the prediction and optimization of clinical outcomes of patients with aortic stenosis and after transcatheter aortic valve replacement. And today we were fortunate to have him talking about this very topic in his talk titled Optimizing the Management of Aortic Stenosis, the Paradox of Progress. So with that, I'll let Dr. Elmariah take it away.
Great. Thank you so much for that kind introduction. Of course, it's a pleasure to chat with all of you today and to review this topic that is one that is near and dear to my heart, and something that I think, as you'll see, there's still a lot of work to be done in this field. So very excited to share some of this work with you guys. I'll begin just by sharing my disclosures. And so my objectives for the day are first to review the rapid evolution and expansion of TAVR. This is work that I know many of you will likely be familiar with. We'll quickly review it, demonstrate some of the tremendous progress that we've made over the last decade or so, and then also to explore the challenges and shortcomings that persist despite the tremendous and rapid progress that we've made, and also perhaps some of the progress that we've made will make the case has actually accentuated some of the challenges in the management of aortic stenosis, the so-called paradox of progress. And then finally, we'll introduce some potential solutions to the optimization of patient management. So first and foremost, we'll begin with some epidemiology. It should not be surprising that aortic stenosis is quite common, and it is primarily a disease of the elderly. We see at least moderate aortic stenosis in well over 10% of patients over the age of 70, and nearly 1 in 15 individuals over the age of 80 actually have severe aortic stenosis. And this is a fairly substantial fraction of our population. The reason that becomes more and more relevant as time goes on, of course, is that the global population is aging. By 2050, we are expecting that the number of people over the age of 65 will more than double across the world. And so that will essentially result in 1.5 billion patients, or billion people, over the age of 65. And of course, many of those, based on the current epidemiology of the disease, will have significant aortic stenosis. And this is further magnified by the fact that aortic stenosis is known to have a tremendous and very rapid clinical impact when not treated. So here I'm showing kind of the landmark paper or figure from Dr. Eugene Braunwald and Ross back from 1968 that essentially proposes this natural history of aortic stenosis and indicates that once symptoms develop, patients on average have a 1 to 2 year survival. Of course, 50% of patients die within that period of time, and it does have some relationship with the type of symptom that they are presenting with. But in general, clinical presentation is the triad of angina, syncope, or heart failure symptoms. And again, so far, this should not be very new to many of you. But what is perhaps less well appreciated is just exactly how substantial this burden of mortality is when aortic stenosis is not treated. So here I'm showing 5-year survival of patients with several leading causes of cancer death. And as you can see, the 5-year survival rate with severe inoperable aortic stenosis is below each of these causes of death. So the prognosis is absolutely dismal for symptomatic severe aortic stenosis when it is not treated, with only 3% of patients alive at 5 years. Now, given that very dramatic burden of mortality risk, and of course there's associated morbidity as well, it's really quite eye-opening that back in the early 2000s, the Euro Heart Study demonstrated that approximately 30% of patients with symptomatic severe aortic stenosis over the age of 75 did not receive a valve replacement. And at the time, that is because surgery was the predominant therapy for aortic stenosis, and many of these patients were deemed to be too old or to have too many comorbid conditions or perhaps neurologic dysfunction and low EF, and therefore could not undergo aortic valve replacement. And so these patients essentially were left to die. And as I mentioned before, many of them would meet their demise within just 1 to 2 years. So it is on that background that TAVR was introduced. And here I'm showing the myriad of randomized clinical trials within the TAVR space from the first Partner 1B study, which was looking at patients with extreme surgical risk, to the more recent Partner 3 study, which of course focused on the lowest risk patients over the age of 65 years. And so going through these quickly, so the Partner 1B study, for those of you who are not familiar with it, was a randomized clinical trial randomizing against standard of care for patients that were at extreme risk for surgery. So these patients were randomized either to undergo TAVR or nothing, essentially medical therapy alone, and perhaps valvuloplasty in some instance. 358 patients were randomized. This was published back in 2010 in the New England Journal. And of course, it did not take long for the study to demonstrate a very robust survival advantage when the aortic valve is treated with TAVR, despite the fact that these patients were arguably some of the sickest patients ever to be randomized in a cardiovascular trial. Then we moved on to the Partner 1A study, in which we looked at patients that were slightly healthier. They could undergo surgery, but at increased surgical risk. They were deemed high risk, which at the time corresponded to a STS predicted risk of operative mortality of over 8 to 10%. Patients were randomized in a 1-to-1 fashion against surgery. Nearly 700 patients were randomized. Again, another New England Journal publication. And here we saw with this relatively early generation of TAVR, this is first generation device, that death from all causes was essentially equivalent with TAVR versus SAVR at 24 months. And this, of course, really opened the door and expanded the indications for TAVR and led to FDA approval in high-risk patients with symptomatic severe aortic stenosis. And with that success, of course, things continued. And so next we shifted our attention to intermediate risk patients. Again, another 1-to-1 head-to-head trial versus SAVR, this time with 2,000 patients in the Partner 2 study. another New England Journal publication. And in this setting, with the primary composite endpoint of death from any cause or disabling stroke, there actually seemed to be a slight, although statistically insignificant, advantage to TAVR. But again, very robust and meaningful results that was the basis for expansion of TAVR into this slightly healthier population as well. And then finally, the Partner 3 study, the lowest risk patients. These are patients over the age of 65, essentially all comers, with a STS risk of less than 3%. These are the slam dunk patients that surgeons should be very excited to operate on. 1,000 of these patients were randomized in a 1-to-1 fashion against TAVR. And the results were quite dramatic, looking at a composite of death, stroke, or rehospitalization, with superiority demonstrated with TAVR for that composite. Although I will say the mortality signal was really essentially the curves are overlapping in most of the studies. Now, several other ongoing randomized trials were also concurrently being executed, including one in Europe and also the Evolute study. We actually performed a meta-analysis looking at 1-year mortality of a meta-analysis of randomized clinical trial data, and it did in fact suggest that mortality at 1 year was less with TAVR than it is with surgery. And since then, of course, we have several studies demonstrating the long-term durability of these results. Here I'm showing data from the Evolute low-risk trial with 4-year outcomes. This is the primary endpoint of all-cause mortality of disabling stroke. And you see that the curves are separate, with the advantage going to TAVR, and that result remaining relatively durable out to 4 years, and perhaps the curves are actually separating a bit. Just last month at the TCT meeting here in San Francisco, the 5-year outcomes of the Partner 3 study were actually presented. This again is the low-risk clinical trial, 1-to-1 randomization, surgery versus TAVR. And you see that with the composite of all-cause death, stroke, or rehospitalization, the curves started separate. They are nearing each other, and I suspect will continue to overlap over time. There is 10-year follow-up planned for this trial, and so really it will, hopefully 5 years from now, we will have tremendous insights into which of these therapies is best for our patients. The all-cause death curves, just looking at the one component of the primary endpoint, I think it's important to highlight that the curves have crossed, although for the most part do remain largely overlapping. And I've listed some of the reasons beyond the 24-month time point that the TAVR arm was felt to see a bump in mortality. So essentially there were 6 excess cardiovascular deaths. All of those seem to be due to traumatic head injury or falls, and then 9 excessive non-cardiovascular deaths, all of which were related to either COVID-19, cancer, or sepsis in 3 cases. But regardless, I think the burden of evidence really suggests that TAVR has become a very viable alternative for patients over the age of 65, and is at least as good as surgery. And I think here we're seeing hemodynamic data that also further supports that. Of course, one of the primary shortcomings that's always been the concern with TAVR is that we don't know how long these valves will last. And certainly I think that is true. But so far, based on the randomized clinical data with echocardiographic core lab adjudication, we see that valve durability seems to be consistent and very comparable, if not slightly better, than what we see with surgical bioprosthetic valves out to 5 years. And there's some anecdotal data out to 8 years. So with that, of course, I'm sure you're all aware that the American Heart Association and ACC guidelines did change to endorse TAVR back in 2020. Essentially, TAVR is considered the primary mode of treating symptomatic severe aortic stenosis in patients over the age of 80. In patients under the age of 65, surgery is still deemed the dominant and more preferred strategy. I would say most of those patients are felt to be appropriate for SAVR primarily because they have over a 20-year life expectancy. And that life expectancy is very important and highlighted within the guidelines. And I mention that because certainly if you have younger patients that do have a variety of comorbidities that limit their survival, TAVR may be reasonable, but we really try to avoid the use of transcatheter therapies in those younger patients, again, excluding those unique situations. Now, the gray zone, of course, is 65 to 80. And this is a patient population in which really the guidelines endorse a shared decision-making approach in which we have to understand the patient's priorities or preferences, their goals of care, and of course, assuming that both are anatomically feasible, really rely upon the patient's preference for guiding the treatment decision for whether they should undergo surgery or a transcatheter therapy. So a lot of fairly impressive results with TAVR, and so it is not surprising that in the United States, the volume of TAVR procedures has grown quite rapidly. You see actually TAVR is that orange curve that has very rapidly risen to 80,000 cases annually within the United States. And this is in 2020. I believe since then, we actually have hit 100,000 cases annually. The blue curve is the surgical aortic valve surgeries, inclusive of combined procedures with other valve procedures and with CABG. You see that there's been a slight decline, but the good news for our patients and for patients with severe aortic stenosis is that we are treating more of these patients. So thankfully, the total number of annual AVRs has nearly doubled over just the last 8 years. And now in the United States, we're well over 130,000 AVRs performed annually, which I think is very clearly a success. In concert with that, we've also become much better at doing the procedure. So back in 2012, when the TVT registry was launched, after FDA approval of TAVR, the in-hospital mortality for transcatheter aortic valve replacement was over 5%. Now with the evolution of the technology, with the introduction of lower profile devices, with the transition to a transfemoral approach in 95% of patients, and of course also with the increasing health of our patients as we've expanded the indication, that in-hospital mortality is now less than 1%. Median length of stay nationally is only 1 day. The stroke rate is 1.4%. Conversion to surgery is under 0.3%, and the need for pacemakers is under 8%. So it's really quite remarkable. I mean, this technology over a very short period of time has evolved to become the standard of care in these older patients. And to put this in perspective regarding conversion to surgery, that rate is actually less than it is nationally with PCI at 0.4%. So really the safety of this technology has really very rapidly reached the epitome of outcomes. So the question then becomes, are we done? You know, is aortic stenosis management essentially set? Are we done? Are our outcomes perfect? Are we doing everything we need to do? And of course, we're not. There's a tremendous amount left to be done. And that's really the primary focus I would like to talk about today. And so just to highlight a little bit. So I reviewed the fact that we only, back in 2001 in the Euro Heart study, a third of patients with severe aortic stenosis were not treated. And so the question then becomes, with the development and introduction of TAVR, and of course I've demonstrated that there's been very rapid adoption of TAVR and an increase in the number of AVRs performed, are we actually meeting the demand, given that our population continues to grow? And so a very simple question that my group tried to answer was, has the widespread adoption of TAVR met the demands of a growing population of patients with aortic stenosis? And so we actually set out, this is prior to my arrival at UCSF, and actually, but with one of our fellows here, Dr. Lee, who was working with me at the time as a resident there. We actually extracted all of the data from our ECHO database. We identified nearly 12,000 patients that had severe aortic stenosis based on aortic valve area from the year 2000 to 2017. We developed a natural language processing tool to essentially extract symptom status from the text of notes. And then we examined AVR utilization based on based on the guideline recommendations for that specific patient. So the patients were categorized into 4 subtypes of aortic stenosis: high gradient normal EF, high gradient low ejection fraction, low gradient normal EF, and low gradient low EF. And you see some of the rates that we see here in terms of the breakdown of the phenotypes. And then again, applied the natural language processing tool to extract symptom status in order to try to deduce how many of these patients actually met criteria for an aortic valve replacement. And what we found was quite eye-opening, I will say. Here I'm showing patients with a class 1 indication for an aortic valve replacement. In patients with a high gradient and normal EF, we were treating 70% of patients. So very similar to what the Euro Heart study had demonstrated years earlier. In the high gradient low ejection fraction cohort, we were only treating about 50% of patients. Unfortunately, we did much worse when it came to the low gradient cohorts, only treating 30 to 40% of patients. And so overall, within the Mass General Brigham Health System, over this nearly 20-year period of time, only 50% of patients with symptomatic severe aortic stenosis with a class 2A or class 1 indication for AVR actually received the AVR. And these results were tremendously eye-opening. First and foremost, I want to just emphasize these, and I'm sure it comes as no surprise, but these are 2 institutions that not only academically are very highly regarded, but in particular, their cardiac surgical programs are among some of the highest volume in the country. And both institutions have high volume TAVR programs and were involved actually in the Partner 1 studies. So they were amongst the first sites to perform TAVR in the country. So clearly, this is a health system in which there are very few, one would think, barriers to treating aortic stenosis in particular. And unfortunately, despite that, we saw that only half of patients were being treated. And this came at significant consequence to our patients. So across the spectrum of phenotypes of aortic stenosis, there is very clearly a survival advantage with aortic valve replacement. And the one I would like to highlight the most is the high gradient low ejection fraction cohort. This is a patient population. The reason I highlight this group is because within the clinical guidelines, low ejection fraction qualifies as a symptom. High gradient, of course, very clearly defines severe aortic stenosis. So this is a group in which there is very little question that these patients met the clinical indication for AVR. So even if one were to question the merits of a natural language processing tool, or to question whether all low gradient patients that we've identified, low gradient severe AS patients that we've identified truly had severe AS, which honestly, a lot of them likely did not. This group in particular are ones that clearly met the clinical indications for AVR. And yet we did a very poor job at treating them. And as we can see, the survival advantage in these patients is quite remarkable. Now, when we look at the trends over time and with the introduction of TAVR, wanted to get a sense if we were treating a greater proportion of patients with severe aortic stenosis who were in need of AVR. And while TAVR did augment the delivery of aortic valve replacement, what we found was that the number of patients that had an indication was actually outgrowing the growth in aortic valve replacement. So we did an okay job keeping up to some extent with the high gradient patients, but especially with the increasing recognition of the low gradient severe AS phenotypes. I think that cohort in particular is far outpacing our ability to deliver AVRs. The other very important observation is that of the patients that did not receive an AVR, 83% had not been referred for the procedure. They were not sent to a surgeon and were not sent to a heart valve specialist. So these are cases that were either just missed or, and I'll get into some of the reasons later, or the decision was made to not refer them and not pursue treatment before they actually got to the valve specialists. Now, just last week, I believe, there was a paper published by one of my colleagues, Philippe Genero, similarly looking at the rates of aortic valve replacement for aortic stenosis. And this was a very innovative and impactful study published in JACC. They actually leveraged the CardioCare database, or Ignite database. This is essentially a large data platform that incorporates with echocardiographic data sets and also with Apex and extracts a lot of echo parameters within a structured format. And it included over nearly 600,000 patients with at least a core amount of parameters that allow for the quantification of aortic stenosis and aortic valve disease. It included over 1 million echoes. And their findings were quite stark. So first and foremost, you see that of their 600,000 patients, about 70,000 of them were diagnosed with some degree of aortic stenosis. Half of those patients had mild aortic stenosis, 20% had moderate aortic stenosis, and about 18%, 17% had severe aortic stenosis. Now, very interestingly, they highlighted 3 primary learning points from this analysis. First and foremost, ranged or intermediate diagnoses are common. So 13% of patients did not have a clearly defined severity of aortic stenosis, as is endorsed by the American Society of Echo and the American Heart Association and ACC. What I mean by that is these were cases in which there was a challenge in grading the severity of aortic stenosis. And so the formal echo reports indicated that the patient had mild to moderate or moderate to severe degree of aortic stenosis. And again, this kind of middle ground diagnosis is not something that is endorsed by the guidelines. What is very eye-opening is that those patients that were in the intermediate range actually had a prognosis that was similar to the next most severe AS grade. So you see that the moderate to severe aortic stenosis cohort had a 4-year survival, a 4-year mortality rate that is equivalent to the severe aortic stenosis cohort. Very similarly, the mild to moderate AS cohort had a 4-year mortality without aortic valve replacement that's very similar to the moderate aortic stenosis cohort. And so they do make the argument that it likely makes sense to upgrade these patients when uncertainty exists. Next, in confirming a lot of the findings that I'd already mentioned to you regarding the undertreatment of aortic stenosis, if anything, this analysis suggests that the real world treatment rate of aortic stenosis is actually much worse than anticipated, with only 60% of patients with severe aortic stenosis receiving an AVR within 4 years of the initial diagnosis. And of course, this has significant consequences when we look at mortality, with marked increase in mortality rate in patients with severe aortic stenosis when the valve is not treated. So another horrible shortcoming across the country is the fact that we really have done a very poor job of expanding the availability of this very novel technology to minority populations. So here I'm demonstrating the racial breakdown of patients who receive TAVR across the United States since 2015. And unfortunately, we see that it is largely a flat curve, with 92% of patients receiving TAVR across the US being white. So only 8% of patients are of a minority status. 4% of those are Black, and 4% are other. So really quite stark, because certainly this is not consistent with the demographic breakdown of the United States population, and is not consistent with the epidemiology of the disease either. And so clearly there's disparities and challenges to care that we need to address in order to mitigate these findings. And so the next question then, having established these limitations, so again, the fact that we're under-treating patients with disease and the fact that there are tremendous racial and ethnic disparities, is how do we address it, and what is the cause? And so when we think about the causes, it's important to look at aortic stenosis as a continuum of care, and to think about the various stages of disease from when one is healthy to the early stages of development of aortic stenosis, during which the disease progresses in a latent fashion, to its diagnosis and how that diagnosis is initially made. Of course, thinking about the transition from diagnosis to treatment, and of course, ultimately to recovery and augmenting post-aortic valve replacement outcomes. And at each one of these stages, several obstacles can exist, and these relate to a variety of factors, including the patient and the patient's beliefs and knowledge. And so there is unfortunately a lack of patient recognition of valvular heart disease as a whole, but also of severe aortic stenosis' impact, of the treatment options and of the risks, not only of the therapies that we can offer, but also the risks of not being treated. I think there are challenges in the recognition, auscultation, interpretation of echoes, and of symptom assessment, and add additional barriers to the management of patients. And then finally, I think it's important to also recognize that physicians don't all share the same beliefs, and there are frequently biases amongst physicians, or barriers within healthcare systems that mitigate the ability to treat patients in an efficient manner. And there are also challenges with suboptimal transitions of care that I will highlight. And so here's just one example, focusing at the provider. So here I'm showing data from the Optum database. This is a large insurance-based data set that includes administrative healthcare data and ICD diagnosis codes. And the investigators look to see, to determine the rates of referral for AVR in patients who met criteria for an AVR, who had a class 1 indication for AVR, for symptomatic severe AS. And they look to see whether different providers had different rates of referral. And as you can see on the left-hand side, there is a tremendous variability in whether certain cardiologists referred their patients for an aortic valve replacement. And across the spectrum of treatment rates, there's essentially a twofold increase in a patient receiving an AVR, depending on whether they saw a physician in the bottom quartile of this of the physicians versus the top. Similarly, the mortality rate, depending on which cardiologist one saw, was actually 22% higher if you happen to be seen by one of the providers that was less likely to refer you. So really, it shows that physician behavior is having some impact on whether patients are referred, and consequently having an impact on whether patients survive. Similarly, the specialty, if you look at the right-hand side, the specialty of the providers is of significance. So If a patient is seen by a primary care provider, their outcomes are very different than if they're seen by a cardiologist. The rates of aortic valve replacement, as expected, are nearly double if a patient is seen by a cardiologist. And similarly, the mortality rate is much improved if a patient is seen for aortic stenosis by a cardiologist as opposed to by a PCP. And there are additional, more structural challenges to the management of aortic stenosis. Here I'm showing data from Ashwin Nathan, who's an interventional cardiologist at Penn. Penn is a very large TAVR program, also again has a very robust surgical program. And that becomes relevant here in a second. But what Dr. Nathan did was actually look at the density age-adjusted TAVR rates by zip codes across the country, but here I'm showing the greater Philadelphia region. And as you can see, kind of in the middle of that graph, the white with the star in the middle is actually the lowest rate of TAVR, age-adjusted TAVR rate. So essentially, those are the patients that are getting the lowest or less likely to receive a TAVR. And that star in the middle is actually the Hospital University of Pennsylvania, which is one of the highest volume TAVR programs in the country. But it is also the neighborhood, if you're familiar with Philadelphia, that is West Philly. And that is a neighborhood that has a very limited socioeconomic status. That is an area that is predominantly Black and Hispanic patients. And unfortunately, these are the patients, despite being next door to the hospital that provides TAVR, are not able to receive the care that they need. And so the question then becomes, what other systematic obstacles are there in the management of these patients? And so we have to really start thinking outside of the box and outside of our comfort zone a bit and think about some socioeconomic challenges that we really don't think about on a daily basis, such as patients that have difficulty with transportation or language barriers, or not having the financial resources literally to take a day off of work to go get your TAVR CT, or not having somebody to care for another family member who's at home sick. So it is a challenge for us to be able to break through some of these barriers. And unfortunately, I think some of these more structural or systematic obstacles are the ones that contribute to some of the racial and ethnic disparities that we see across the country. But beyond that, within our data, we've also similarly broken down the causes of underutilization of aortic valve replacement, and I've tried to categorize them here into clinical factors that I think for the most part certainly may be appropriate. There are patients, of course, who are too sick for these interventions, and so age does contribute to that. But the other predictors that we identified were low ejection fraction, anemia, comorbidity. There are several patient and provider-based biases. Again, I list age again because I've had many patients that come to me and tell me, am I too old to have this done? And it's only after really explaining the disease pathology, the natural history, and also the risks associated with the procedure do they change their tune and I think agree to proceed. There are similarly gender-based obstacles. We found that female patients are far less likely to receive treatment. And I've already demonstrated that the rates of AVR in patients with low gradient severe AS are far, far lower. And so that is certainly an area where I think we can do much better with education. In regards to the health system and challenges with diagnosis and transitions of care, so if a patient received if the index echocardiogram that diagnosed aortic stenosis happened to be performed in the inpatient setting, those patients were less likely to get an aortic valve replacement. And the reason for that is presumably that patients, you can imagine a patient that's admitted for a non-cardiac cause, receives an echo, may not have longitudinal cardiovascular care. Those patients, unfortunately, are more likely to also be of minorities and of low socioeconomic status. And their outpatient providers, if they have any, may never know that an inpatient echo was performed. And so again, these transitions of care contribute to the undertreatment of these patients. Similarly, if the echocardiogram that diagnosed severe aortic stenosis was ordered by someone who is not a cardiologist, patients were less likely to then be treated appropriately. And of course, I've mentioned low gradient severe AS previously. And just to demonstrate how robust some of these factors are, here I'm showing the proportion of patients that received AVR by age, by decade of life. And we see that only 1 in 4 patients over the age of 80 with symptomatic severe aortic stenosis actually received aortic valve replacement. So the huge majority of these patients, unfortunately, are likely succumbing to this pathology. So we then took another step, thinking about that pathway. We know that when patients actually have an echo, they have severe aortic stenosis. We've identified a number of factors that contribute to whether or not patients get treated. But what about taking it a step further? So they get the echo, but we looked at a very simple point within that patient's care pathway. Specifically, the assignment of an ICD billing code indicative that somebody recognized clinically the aortic stenosis. So we took patients that actually had aortic stenosis, identified an echo, identified nearly 15,000 patients. We excluded patients that already had an ICD billing code indicative of aortic stenosis and looked at the ones that were remaining and simply looked to see what proportion of patients that have echocardiography confirmed aortic stenosis actually subsequently received the AS billing code within the following year. Again, the billing code is really in the EHR what indicates recognition of that entity. And what we found was that, first of all, somewhat as expected, rates of recognition were greater with greater severity of disease. So patients with severe aortic stenosis, about 85% of patients received the billing code within 1 year. With moderate, it was only 70%. What was a bit surprising to us, however, was that there is a racial and ethnic disparity, even at this very simple step in the patient's care. So despite having enough access to the health system to receive an echocardiogram, Black patients only received a billing code in 60% of cases. So really quite stark observation. Similarly, Hispanics did not have the same rate of recognition as white patients did. And so overall, amongst patients with confirmed aortic stenosis on an echo, about 1 in 3 patients with moderate aortic stenosis and 1 in 7 patients with severe aortic stenosis lack a clinical ICD diagnosis of aortic stenosis after 1 year. And when we look again at some of the contributing factors, very similar to what I showed before. So if you're a woman, you're less likely to get a billing code. If you have more comorbidities, you're less likely to get a billing code. If your echo was ordered by someone who is not a cardiologist, or if the echo was performed in the inpatient setting, again, suggesting there are barriers to transitions of care and limitations to access to specialty care. Unfortunately, both of those factors contribute to the receipt of an ICD billing code. And as I mentioned, racial and ethnic disparities, even with this simple step, do exist. It's not simply access to the high technology, high touch therapies such as TAVR. So then we delved in and took a deeper dive into some of these patients' charts to really try to understand if a patient was seen by a provider, what was happening if they were not getting an aortic valve replacement. So here we took 140 patients, all ambulatory, just to simplify things. We excluded inpatients. These are ones that had severe aortic stenosis with symptoms from 2016 and 2018, so far into the TAVR era, after the approval of TAVR for intermediate and low risk as well. And here are the causes of why patients did not receive an AVR. Now, some of these reasons, I think we have to give clinicians the benefit of the doubt, and some of these certainly are justifiable. So for example, I have the green boxes around 2 such reasons. So in 1, aortic stenosis not felt to be severe in 15% of cases. Great. Again, I think we have to trust the clinical providers and take that as it is. In 13% of patients, symptoms were not attributable to aortic stenosis. Again, I'll trust the clinical judgment of the providers and assume that those are appropriately deferred aortic valve replacements. That makes up 1/4 of the patients that were not treated with aortic valve replacement. But let's look at the red boxes. So watchful waiting for symptoms to worsen. That alone is nearly 1/4 of the patients. But I must admit, this one really gets to me, because there is nowhere in the guideline or in any other literature in which there is a certain severity of symptoms that has to be reached before aortic valve replacement as a life-saving therapy is offered. Any symptom really should be considered a trigger for aortic valve replacement in these patients, any symptom that's attributable to the valve. 2% of patients were lost to follow-up. 20% of patients, the aortic stenosis was identified, was acknowledged, and the evaluation initiated, but yet a year later, the aortic valve replacement had not been performed. In 10% of patients, there was no evidence of an evaluation or of any acknowledgement of aortic stenosis, really suggesting that these patients perhaps were just missed completely. And then finally, so all of those, that's well over 50% of the untreated patients. And I think all of those are very clearly erroneous, and that those patients did in fact warrant much more efficient evaluation and treatment. Now let's focus on the yellow boxes. So 7% medical futility. There is absolutely a cohort of patients in which AVR, whether it's TAVR or SAVR, is medically futile. And in general, we only offer these therapies if there is a perceived and predicted survival of at least 12 months. There's another 11% of patients in which the patient declined. But the reason I highlight these in yellow is that neither of these groups, in no cases of futility or of the patient declining, was the decision to defer AVR made in conjunction with a valve specialist. And that, I think, is a very important point, especially when we think about patients declining, because you have to know what you're declining. And you also have to understand the consequences of that decision. It's for this reason that the guidelines have a class 1 indication for patients with severe valvular heart disease to be referred to a multidisciplinary heart valve team when an intervention is considered. It is also for this reason that there's a class 1 indication for a shared decision-making process for anyone in whom an intervention is even contemplated. So again, these referrals are not necessarily for the procedure. The referral is for a discussion to consider the appropriateness and for the patient to learn about the procedures, the natural history of the disease, and the consequences of whether they select AVR or nothing, and similarly, whether they select TAVR or SAVR. And unfortunately, the shared decision-making process does not happen with substantial frequency, despite the fact that there is this class 1 indication. So here I'm showing the steps to the shared decision-making process. Just to clarify it, I will emphasize the fact that shared decision-making is not simply the consent process. It is not simply going through and telling the patient the risks and the benefits of the procedure. It really goes beyond that and seeking the patient's participation, educating them about the disease process, about the alternatives, and about the benefits and the risks, yes, but it really it is built upon a desire to engage with the patient and have them be part of the decision, and also to make that decision in a manner that is respectful of the patient's values and preferences, and to collectively reach that decision. And this certainly results in better patient satisfaction and ensures that they are comfortable with the decisions that are being made. But unfortunately, at least within the literature, Amongst 15 studies that have been published looking at shared decision-making for severe aortic stenosis, very few included the various components of the shared decision-making process. And so I think it is very clear that we're doing a very poor job at implementing the shared decision-making process. And because of this, patients often do not feel empowered to express their goals, and to voice their preferences and priorities. Shared decision-making is unfortunately not yet common practice. Many of us just don't know how to apply it and how to do it. And there's a lack of evidence with regards to patient outcomes once shared decision-making is performed. And all of this contributes to very unfortunate situations where patients say things like this, where they will highlight the fact that decision was very difficult and that they had a lot of questions, and they go through a procedure without fully understanding it. Now, the ACC and CardioSmart has put out decision aids to help guide the shared decision-making process. I'm showing just a snippet of it here. Part of it is demonstrate the comparative benefits of TAVR versus SAVR and risks. And we have demonstrated that this decision aid does in fact help to inform patients. It improves their knowledge score in a small randomized study that we conducted. It also helps to improve communication with the patient. And I'll also just highlight that the heart valve team in and of itself, and the multidisciplinary discussion that is had during those visits with both a surgeon and an interventionalist, also facilitates the shared decision-making process, because then the patients actually recognize and appreciate that there is a decision to be made when they see the two providers. I'll try to speed up here because I know we're running low on time. But unfortunately, as we go through this, we have to acknowledge that we too have uncertainties in the management of aortic stenosis. We don't really understand the durability of transcatheter heart valves. Honestly, we don't understand the durability of surgical valves, and not all surgical valves are created equal. So we have to think about lifelong management of these patients and really make sure that our patients recognize the sorts of things that may happen down the line after they're treated for their aortic stenosis. And the shared decision-making process is a tool in the face of this uncertainty. It acknowledges the uncertainty and tries to understand the patient priorities and formulate a joint approach to address these issues. So a few take-home points. We've highlighted that TAVR has expanded exponentially, and it has improved the delivery of aortic stenosis, of aortic valve replacement for aortic stenosis. However, in the face of this improvement, we now have greater disparities and less utilization of AVR in treating patients with this very morbid disease. We're facing marked ethnic, racial, and gender disparities, and decisions for these patients are often made without their engagement within the process. And so the goal, of course, in managing this disease is for us to have appropriate guideline-driven therapy that is multidisciplinary and team-based in regards to delivery of care and decision-making, care that is delivered in a culturally competent manner. And of course, we want to break down some of those barriers and provide universal access to this life-saving therapy. And these goals are high and they're lofty, and it will include it will mandate a collaboration of medical societies, communities, and patients as well. I will say more and more digital technologies are being leveraged to help address some of the challenges that I've outlined. Here I'm showing papers actually from our UCSF group. You'll see many names that you recognize. Of course, leveraging artificial intelligence and machine learning and large language models to try to perform population screening, whether it be with automatic assessment of echocardiogram or electrocardiographic data, or leveraging automatic interpretation of echocardiograms to identify structural heart lesions. And of course, these can be applied for valvular heart disease as well and could be utilized for population screening. I myself am running a randomized clinical study currently in which we are randomizing providers to receive electronic notification when their patients have an echo demonstrating severe aortic stenosis. And we've actually completed enrollment of over 950 patients and are currently in the follow-up stage with this study. And then finally, I want to highlight the Target AS initiative that is built upon some of the data that I've shown and is really a novel registry that seeks to explore and develop quality metrics for the management of aortic stenosis. As opposed to the current registries, which are very procedurally oriented, such as the TVT registry of TAVR patients or the SDS registry of surgical AVR patients. This is one that seeks to capture patients earlier in the process and to follow them prospectively until they receive treatment. The initial study included the sites listed here. UCSF is joining. We actually just received approval within the last month or so. And the primary goal of this initiative is to set a quality metric that will focus on the proportion of patients treated with AVR within 90 days of diagnosis. So this really will be a game changer, I think, hopefully in the management of valvular heart disease in the future. And then finally, to help augment the shared decision-making process, myself and Dr. Sapucha at Mass General are leading a multi-center initiative. This is a step wedge cluster randomization trial in which we are actually leveraging the American College of Cardiology decision aid and also clinician training to help bolster the implementation of the shared decision-making process. And this is a study that includes 8 sites across the country, as well as several other collaborators and patient advocates from across the country, and that will be starting soon. So I'm sorry I ran a little bit over. Very clear that we have made a tremendous amount of progress in managing aortic stenosis and valvular heart disease, but also we still have a long way to go to optimize the management of aortic stenosis. And with that, I will stop. Thank you all for your attention.
Thanks, Dr. Elmariah. We've had an active chat. I just want to acknowledge that we are at time, but we still have more than 60 people, or about 60 people on the chat. It was a greatly attended talk. So if anyone wants to unmute themselves and ask one of their questions, that would be fine. Otherwise, I had a question about the trial that you have about alerting providers. It's kind of about next steps. It made me think about the radiology reports that often prompt people to do things by guidelines and maybe consider other tests. Do you know what level of evidence that radiologists use to incorporate that into?
That is a great question.
And is also that your vision?
Yeah, it is. I've had a lot of conversations about this very topic and use that exact example. I mean, so you have a radiologist who on a CT scan will find a small nodule, and because of that small nodule, they will tell you exactly when you need to obtain a follow-up CT scan. They'll tell you exactly how to manage that patient. Unfortunately, on the cardiology side, we'll have an echocardiogram that has severe aortic stenosis that will kill the patient much faster than that lung nodule, but yet there is no mention made of what else needs to be done. And very frequently, unfortunately, nationally, there are many situations where the echo report does not even say severe aortic stenosis and won't give any indication that there's a problem. It will just simply list the numbers and the aortic valve parameters. That is a philosophical difference, I think, between cardiology and between radiology. The radiologists, to be completely frank, were sued, and there were legal concerns about missing a nodule. And that's why they changed their practice and started incorporating those recommendations. I think there are ongoing talks with the American Society of Echo to try to bolster recommendations within the echo reporting system. I know that Dr. Tolstrup here is trying to have some of those recommendations incorporated. I'll also mention that myself and Dr. Luke Zier over at the General are working on developing a electronic health record based care path that would essentially give alerts within Epic as opposed to just an inbox message, but really something that's much more in your face and harder to avoid, to help facilitate referral of patients that are found to have significant valvular heart disease. And we'll we'll develop it there at the general and expand it to UCSF hopefully, and are planning the DETECT-AS2 study as part of that initiative as well.
Great, thank you. Did I see someone in the 11 conference room? I think it's a little blurry.
Hi, James, it's Rita. And hi, Sammy.
Hi.
Thanks so much. It was lots of great information. I had just two sort of concerns I wanted to run by you. One is about this low EF group. Have they been included in any randomized trial? Because there are a lot of reasons people don't have low EF, and I don't think many of them would necessarily translate into benefiting from an AVR. And the other one is about durability. Sorry.
Yes, so I think so the low EF patients were included within the partner trials. I mean, the studies included patients with an ejection fraction down to 20%. There's one publication looking at patients with lower ejection fraction that were beyond what was studied in the randomized studies, and did suggest that those patients did benefit as well. I will say that
they were asymptomatic. Sorry, Sammy, because it's the asymptomatic part that is.
Well, I think the issue is that the afterload of the valve in somebody who's got a cardiomyopathy is felt to be detrimental. I will say there's, even in moderate aortic stenosis, there are data suggesting that, and you'll hear more about this. I actually took those elements out of my talk. But Philippe Pipero will be talking about that next week as well. But even with moderate aortic stenosis in patients with reduced ejection fraction, there are substantial data suggesting that those patients may benefit from intervention and alleviation of that afterload, even though it is less afterload than one will see with severe AS, of course. The DETECT-AS study is a randomized study specifically focusing on that cohort that completed enrollment about 6 to 12 months ago, and we're currently in the follow-up phase. And so hopefully we'll have good randomized data within the coming year or so as to whether early TAVR in patients with moderate aortic stenosis but reduced ejection fraction is clinically advantageous. And of course, there are also other moderate aortic stenosis studies, but those are not focused as much on low EF. In terms of valve durability, so that is, tell me exactly kind of what the question is, because there's a lot of.
Yeah, I was just putting it out because we're past time, and I know and you did mention this during your talk that the studies now maybe go up to 10 years, but when you're talking, clearly there's been an exponential increase, and it's in younger patients, and we don't have longer data, and we know that mechanical valves last 20, 30 years, and there is surgical AVR. So I still personally am very concerned about recommending a transcatheter aortic valve for someone with more than a 10-year life expectancy when we don't have the data, and I think they'll do fine from a surgical AVR.
So I think the data for surgical AVR is quite poor. I'll start with that, and I'll give you some examples. So first and foremost, I think if you have somebody who's a candidate for a mechanical valve, they should get surgery. I mean, I agree with that completely. So if you have somebody under the age of 65 and they have agreed to get a mechanical valve into lifelong anticoagulation, they should get surgery. No questions asked. If they are getting a bioprosthetic valve, I do think that the surgical data is, I mean, honestly, the most robust data that has echocardiographic core lab adjudication is in the TAVR trials. As you know, surgical valves are not all created equal, and there is not long-term data with most of the surgical valves. And I think we're living this with patients that receive the MitraFlow valve or the trifecta valve that are falling apart within 7 years of implantation. And if anything, those are actually the reason that we're doing so many valve-in-valve procedures. So those valves were complete garbage, and unfortunately they were approved by the FDA kind of through a 510K approval, and this assumption that all surgical valves are created equal. Now, there are, however, great surgical valves. I mean, and several that have 15-year retrospective data. Although I will mention that most of that data, and maybe I can pull up the slide here in a second, but most of that data utilizes the endpoint of surgical reintervention and not echocardiographic follow-up. So there is a great study published by the Brigham. It's one of the largest studies that looks at long-term durability of valves, and they actually broke patients down by age. And if you were 75 years or older when you got the surgical AVR, the Kaplan-Meier curve stayed at 100%, meaning that 0 of those patients had valve degeneration. The problem is that valve degeneration was defined by reintervention and not by echocardiographic deterioration of the valve. So to give you an example, if one of those patients at the age of 85 had a valve that failed and they did not get repeat surgery because they were too old and they died, that was not counted as an event in that study. And so that, I think, is the problem. So the surgical literature has not had a standardized definition for valve degeneration, and similarly has not had standardized follow-up, echocardiographic follow-up, to really identify whether the valves deteriorate or not. All the studies that have been done that have gone in these randomized studies that have gone out to 5 years have demonstrated equivalence. The data from Europe that goes out to 8 years has similarly identified equivalence with echocardiographic parameters. And beyond that, I think there's question with both. I don't think we know. I don't think we know how long most of the surgical valves will last, and I don't think we know how long the TAVR valves will last. But there's not much so far. There's no objective evidence as of now that shows that there's an advantage to one over the other. But very different with mechanical valves and very different with the Ross procedure.
All right, I think that was a thumbs up, even though the camera is a little bit blurry. But thank you again for that. Just the purposes of time, I know we're over. That was a great discussion, and thanks again, Dr. Elmariah. Everyone again, we'll have another talk on aortic stenosis next week, so we can carry on the conversation then. See you guys then.
Great. Thank you, everyone.